So, my name is Arifa Siddiqa. I'm one of the consultant colorectal and general surgeon. It's my great pleasure today to introduce our speaker, Mr. Fahiz Muhammad. He is a surgeon who works at the peritoneal malignancy unit at Basingstoke Hospital. He has particular expertise dealing with appendiceal and colorectal tumor that have spread to peritoneal surface, as well as rare cancers such as abdominal mesothelioma. He provides with the cytoreductive surgery and HIPAC, as previously known as sugar baker technique. Thank you, Fahiz. I would also like to introduce the panelist, my colleague, Miss Rachel Agulo. She is a consultant surgeon with particular interest in emergency surgery and bariatric surgery. And I'd also like to introduce one of my colleagues, Mr. Hamza Malik. He has a particular interest in emergency surgery and also research and innovation. He is Research and Innovation Director for Homerton University Hospital. For the speakers and the panelists to know, we have various units in Bangladesh joined up for colorectal and general surgery. And for now, I can see colorectal units for Bangladesh Medical University Hospitals, Dhaka Medical College Hospital, SSMC Hospital, and lots of other individual attendees. Welcome all. Thank you, Fahiz. Shall we start?
Inshallah. Thanks, Arif. Assalamu alaikum, everybody. My name's Fahiz Muhammad. I'm a consultant surgeon, as Arifa said. I'm going to, I'll share my screen in a second, and then I'm going to share our experience with managing appendiceal tumors. Can everybody hear me okay? Perfect. Good. Just share my screen. Okay, can you all see that, my screen now? Perfect, okay. So, I'll give you a bit of background. Basingstoke is one of the two national centres in the United Kingdom funded by the NHS to treat appendiceal tumours and also peritoneal malignancy with cytoreductive surgery and HIPEC. So we were commissioned by the NHS in 2000. Manchester is the second centre that's commissioned to treat appendix tumours, and it was commissioned in 2002. There are three other centres that treat colorectal peritoneal metastases. So for a country the size of the UK and Ireland, we still have relatively small number of centres, but the treatment is centralised. So we are the highest volume centre in the UK and probably one of the highest volume centres in the world. We perform nearly 10 or 11 of these cytoreductive surgeries a week in 3 different hospital sites for mainly appendix tumours, but also for colorectal cancer and for peritoneal mesothelioma that has spread to the peritoneal surfaces. So how do we get involved? Well, we're a small district general hospital. We have a catchment population probably with our sister hospital in Winchester of about 500,000, but many of you will know this man. This is Bill Heald, who many would regard as the father of rectal cancer surgery, total mesorectal excision. And Bill was a colorectal surgeon in Basingstoke. He's still going strong at 90, but no longer operating. And Bill met Paul Sugarbaker, and Bill had a patient who had pseudomyxoma. Paul Sugarbaker came to operate. Brendan Moran is my senior colleague, and Brendan was Bill's registrar. And together with Paul Sugarbaker here, they did the first operation back in 1998. I was a research fellow under Paul Sugarbaker's supervision back in 2001 to 2003. And then I came to Basingstoke about 17 years ago, and I've been a consultant there since 2009. So I just wanted to start with a fairly common presentation for many of you, just to get you thinking about appendix tumors. So a 54-year-old lady, she presents with a short history of right iliac fossa pain, raised inflammatory markers, and she's admitted and she gets a CT scan of the abdomen and pelvis. And this is what the CT looks like. So I think we're probably all surgeons in the audience. I don't know if there are any radiologists, but you can see there's a fairly obvious tumor in the right iliac fossa, and it looks to be arising from the appendix, but no other obvious disease elsewhere. So it looks like it's all contained to the right iliac fossa. I just want you to have a think about what you'd do in this situation. So patients got some mild tenderness, they're not peritonitic. What would you do? Would you laparoscope them and perhaps plan to do an appendicectomy? Would you do a right hemicolectomy? Perhaps just take the cecum? Or would you manage them non-operatively? Or maybe you're lucky enough to have someone who has an expertise and you can phone them and perhaps get some advice. But this is a common scenario, and we get a number of referrals patients with abnormal incidental findings or and obviously abnormal appendix on the CT scan, and people want to know what the best next step would be. So just to give you a bit of background, appendix tumors, often they're an incidental finding. So someone's had an appendicectomy for appendicitis, what you thought was appendicitis, but then a histology report comes back a few weeks later and it turns out to be an appendix tumor. Or they're picked up incidentally on imaging for some other reason. And we know now that patients who present with complicated appendicitis with an appendix mass or appendix abscess, they have a higher risk of having an underlying appendix tumor. So we need to be vigilant and perhaps take things more seriously when people present with complicated appendicitis. In the UK, there's about 70,000 appendicectomies annually. This is a rare cancer, only probably 1% of appendicectomy specimens. And in our own experience in patients who have colorectal cancer, there's an incidental finding of 4% of appendix tumors with that colorectal cancer. So if we are performing an elective primary colorectal cancer operation, we will always counsel the patient for an appendicectomy because you can reduce the risk of an appendix tumor forming, and certainly peritoneal disease from that pseudomyxoma, you can reduce that risk as well, even though the risk is small. So there's a spectrum of disease. On the left-hand side, you can see here an appendix tumor that's not perforated, no peritoneal disease. So an appendicectomy in that instance may be all that's required. And we'll talk about whether you should do an appendicectomy or a right hemicolectomy a little bit later on. When patients present with peritoneal disease, then the situation is a little bit more challenging. And then when patients have high-grade disease with small bowel involvement, then your chances of achieving a cure with surgery are significantly reduced. And why is it of concern and how we manage these tumors? Well, we have managed to standardize the pathology or the pathological reporting of appendix tumors over the last 10 to 15 years. It's still not widely used, but broadly speaking, we can categorize appendix tumors into those mucinous tumors, which are either low grade or high grade. And the difference is in the infiltration or the pushing invasion, which basically differentiates a low grade from a high grade tumor, but you can also get a mucinous adenocarcinoma when you actually get infiltration with signet ring cells. Other appendix tumors which are non-mucinous, so these don't lead to the condition pseudomyxoma peritonei, which is PMP. These other tumors, there are non-mucinous adenocarcinomas of the appendix. There are goblet cell adenocarcinomas of the appendix and neuroendocrine tumors. We're not going to talk about neuroendocrine tumors because they behave in a very different way. But peritoneal disease from non-mucinous and goblet cell adenocarcinomas has a pretty poor outcome, even if we can achieve a complete tumor removal. but the mucinous tumors have a much better outcome if you can achieve complete tumor removal and you combine surgery with hypothermic intraperitoneal chemotherapy. And so essentially, if you identify one of these mucinous appendix tumors, the reason why it's important how we manage them is there is a risk of this condition called pseudomyxoma peritonei or jelly belly developing. We think, although we're not sure, and we're doing a prospective study of patients who've had an appendicectomy for an appendix tumor to see how many of those then go on to develop pseudomyxoma peritonei. So we've got a cohort of about 500 patients who we've been following prospectively. And now with a median follow-up of about 3 years, it's probably just under 10% will progress. So the majority won't, but there's enough of a risk for us to need to keep an eye on these patients so that they don't fall between the cracks and we don't lose them so that they present with advanced peritoneal disease. We think that there's a higher risk of developing peritoneal disease if there's mucin and epithelial cells outside the appendix, but we're not sure. And as I say, I think as the follow-up of our cohort matures, then we'll have a better idea. And we're part of this LAMNet study, which is an international collaborative study where we're essentially pooling all our patients with appendix tumors without peritoneal disease to see how many of those go on to develop it so we can work out the risk of developing pseudomyxoma. Many of you will have heard of this term or will use this term mucocele of the appendix. And it's a little bit of a misnomer in that we know that if these tumors aren't taken seriously, then they can develop peritoneal disease, and that can be challenging to treat. So we're encouraging a move away from this use of the word or the term mucocele. You'll see radiologists often refer to a mucocele of the appendix, and perhaps move towards saying a likely appendix mucinous neoplasm, because that better reflects how these tumors might behave. And I think we should take them a little bit more seriously than perhaps we've done in the past. I think we've seen a shift over the last 5 years, particularly with COVID, in treating appendicitis non-operatively. So many of you, I'm sure, will have managed early appendicitis with our intravenous antibiotics. Things settle down. There was a trend then where initially we would perform a colonoscopy and perhaps do an interval appendicectomy. I think that fell out of fashion. And then many people would say, well, actually, if things have settled down, then you don't need to do anything. But we would caution against that. And certainly if someone presents with an appendix abscess or with an appendix mass, then once things have settled down, we'd recommend that you do a colonoscopy to exclude a colorectal primary tumor or an underlying cecal cancer, and then proceed to do an interval appendicectomy, because they're up to 20% of patients will have an underlying appendix tumor, and in those who are over 40, that incidence increases. So this is from data from Finland, looking at incidental findings of appendix tumors in patients who presented with complicated appendicitis. So just something to bear in mind. And I think this is an editorial by Brendan Moran from a few years ago. I'd encourage you to read it because it covers some of the issues and challenges around managing appendicitis non-operatively. So once you do find the appendix tumor, many discussions in the tumor board will be around doing a right hemicolectomy. And then we have to ask ourselves why. Are we doing this for the risk of lymph node involvement? Or we can't ignore the fact that some of these patients have a risk of developing peritoneal disease, but at the time you perform the appendicectomy, there may be no evidence of peritoneal disease, and clearly the risk of lymph node involvement is unknown. So what is the actual risk? So again, this is a retrospective study that we did looking at patients with high-grade appendix tumors with no clinical or radiological evidence of peritoneal disease. So they'd had their appendix taken out, the pathology had been reviewed. And when we performed surgery, which was essentially a radical right hemicolectomy, taking the ileocolic vessels right at their origin, stripping the peritoneum from the right parietal peritoneum, performing an omentectomy and giving HIPEC. We actually found peritoneal involvement in just under 60% of patients, this with no evidence on imaging. And nearly 40% of that was distant to the right colon, so it wasn't on the right-hand side. But nodal involvement in only 15%. So actually, doing a right hemicolectomy alone is potentially undertreating these patients because the risk of peritoneal disease is much greater than the risk of nodal involvement. So we would discourage people from just doing a right hemicolectomy. And the reason for that is once you open up those anatomical planes, doing a right hemicolectomy, if peritoneal disease then develops in those planes, it can be much harder to clear with surgery, with cytoreductive surgery. And so preserving those planes and doing the whole operation, but combining it with an omentectomy, stripping the peritoneum and the HIPEC, I think gives patients a much better long-term outlook. Now, clearly, we're able to do this in the UK because we have specialist centres that you can refer to. This may be more challenging in countries where that service is not available. I just give you a little bit of background about the pathology, and I think the pathology is very important. So if you have a low-grade appendiceal mucinous neoplasm, it's incidental, there's no evidence of any peritoneal disease, then we'd recommend a colonoscopy because there is a slightly increased risk of synchronous colorectal polyps or tumors. Tumor markers, we use these 3 tumor markers as a quite effective surveillance for development of peritoneal disease, and if they start to rise, then it's a pretty good indicator that there may be some peritoneal disease developing. And currently, we recommend a CT of the abdomen and pelvis at 1, 3, and 5, and then 10 years if there was evidence of a perforation for these patients. And in younger people, then an MRI to reduce the CT exposure. And that will allow you to pick up peritoneal disease early and then decide how best to manage it. In patients with a high-grade tumor or a mucinous adenocarcinoma, we'd recommend the same, the colonoscopy, the CT, and the tumor markers, but we would counsel patients for what we call completion cytoreductive surgery. So essentially that right hemicolectomy to stage the ileocolic lymph nodes, but also stripping the right parietal peritoneum, performing the omentectomy. In women, postmenopausal women, would certainly talk to them about taking the fallopian tubes and the ovaries because there is a risk of Krukenberg tumors developing with these mucinous tumors. In premenopausal women, then it's more of a challenge in terms of how we manage their fertility, but we have that discussion. And then we combine that surgery with HIPEC to reduce the risk and of peritoneal disease developing, but also to stage the ileocolic lymph nodes and decide on whether there's a role for systemic anti-cancer treatment. So as an algorithm, I think if you have a suspected tumor appendix tumor on imaging, then we'd recommend a diagnostic laparoscopy. If you can keep your ports in the midline, then it makes it much easier if patients come to surgery, open surgery, that we can excise those ports because they can harbor mucinous disease. And then if you can do an appendicectomy safely, whether or not there's a peritoneal disease, then do it because that will give us histology, and then we can decide on whether, if this is a low-grade tumor, an appendicectomy alone is probably all that's required. If it's a high-grade tumor, then we might recommend a little bit more. And again, the follow-up as I'd suggested. And in the UK, this is what we would recommend for the management of an unexpected appendix tumor. So moving on to pseudomyxoma. So this is when patients with perforated appendix mucinous tumor develop peritoneal disease. It's a rare condition, probably affects 3 to 5 per million population. And essentially, it's been a model for peritoneal surface malignancy management with the use of cytoreductive surgery and hypothermic intraperitoneal chemotherapy. It was commissioned, the sugar baker technique, as Arif alluded to, back in 2004 by the National Institute for Clinical Health and Excellence. And so there are, as I say, we get 2 centres in the UK that are funded to treat this. So the treatment for this is centralised, and I think we've benefited from that in terms of having 2 high volume centres. And we operate, last year we operated on nearly 300 patients with pseudomyxoma peritonei. So over the last 25 years, what have we learned? So I think primarily that if we can aim for a complete cytoreduction, removing all of the tumor, then patients have the best long-term outcomes. But even if we can't remove all the tumor, we can still benefit patients in terms of quality of life and helping with their symptoms from a maximal tumor debulking, which means essentially removing all of the disease that we can. What stops us from removing all the disease tends to be small bowel serosal involvement. And that's not always easy to establish preoperatively. And sometimes we only find that out at the time of surgery. And this is lesions on the serosa of the small bowel or at the mesenteric border, which we can't remove. And so we'll remove as much disease as we can. Often, if you have widespread small bowel involvement, we'll leave the upper abdominal disease and just take out the omental cake and perform a colectomy and an endoileostomy just to give people symptomatic relief. We know that if we can achieve a complete cytoreduction, we can get up to 90% 5-year overall survival and 70% 10-year survival. The curve at the top, the CC01, basically refers to a complete cytoreduction, which means leaving disease that's less than 2.5 millimeters. The CC2 and 3 is what we call an incomplete cytoreduction, where we're leaving gross macroscopic disease, and you can see that the survival is nowhere near as good. But even if we can't remove all the disease, we can still get just above 40% 5-year survival. And many of these patients, if you did nothing, when they present with advanced disease, they would be dead within a year. So I think there is some benefit in doing a tumor debulking, even if you can't achieve a complete cytoreduction. So what's involved in a complete cytoreduction? Well, often it's all the peritonectomy procedures, paracolic gutters, pelvic peritonectomy, the subdiaphragmatic peritonectomies, a greater and lesser omentectomy. We sometimes need to perform an anterior section, hysterectomy, and salpingo-oophorectomy. We use high-powered electrocautery to burn the disease from the liver capsule, and often we need to perform a cholecystectomy, splenectomy, and in some patients, a partial or total gastrectomy. So this operation, if you've got 4-quadrant disease, can take 9 or 10 hours, combined with the hypothermic intraperitoneal chemotherapy. You can see here the involvement of the pylorus of the stomach, and patients essentially develop gastric outlet obstruction. But if you can identify the left gastric artery, then you can perform a distal gastrectomy. And we use a Billroth 1 anastomosis, which is pretty reliable and robust. Those of you who are upper GI surgeons probably think that's very old-fashioned, but it is quite a useful and reproducible anastomosis. And we know that if you perform that, the gastrectomy, then although the survival is not as good as it is for patients who don't require a gastrectomy, it's still much better than it would be if you were to do nothing. And you can certainly give patients very good symptomatic relief and long-term survival. And we've recently updated our experience with nearly 100 distal gastrectomies over the last 20 years. So how do we assess these patients? Well, we take a comprehensive history and examination. We spend nearly an hour with them in the outpatient clinic. Often they've had quite a long journey to get to us. They've either been referred to gynecologists with suspected ovarian cancer, or because of the rarity of the condition, there's been a lot of diagnostic delay. Our main workhorse is still CT for imaging, although MRI has a role. It's probably not as useful and certainly not as accessible as CT. We use positive oral contrast because it gives us a very good idea of whether there's small bowel involvement, and that's really fallen out of fashion with many radiologists who are just using water now. So it's a bit of a battle to convince radiologists to give positive oral contrast in addition to intravenous contrast. Pathology is really important, and I think again it is a challenge if your pathologists, and many pathologists will never have seen these appendix tumors, or certainly it will be something very rare to them. But actually, an accurate description, and if patients are referred to us, we like to see the histology slides ourselves, and our expert pathologists will review the pathology because it does have a bearing on how we would treat these patients. And tumor markers, as I mentioned, CEA, CA125, and CA199, they are all useful. Radiology is an integral part of how we select patients for surgery, and certainly our radiologists can tell us where those unfavorable sites of disease are that might stop us from achieving a complete cytoreduction. So small bowel involvement, disease around the porta hepatis, the aortocaval groove, all of these sites are unfavorable and will have some bearing or impact on whether we'd be able to achieve a complete cytoreduction. Our radiologists have published this scoring system called the PAUSE score, which is essentially gives us an estimation of the extent of disease. And we use a scoring system that was first described by Paul Sugar-Baker called the peritoneal cancer index, which divides the abdomen up into regions and gives us a score in each region depending on the number of lesions and the lesion size. And the score goes from 0 to 39, 39 being the worst and 0 being no peritoneal disease. And it was initially described for colorectal cancer, where it has a stronger prognostic use. It's less of a prognostic indicator for pseudomyxoma, because we know that even if someone has a PCI of 39, if we're able to remove all of the disease, that's the strongest predictor of good long-term outcome. With colorectal cancer, for instance, if someone has a PCI of above 15, then it is unlikely that they're going to be a long-term survivor, even if we can achieve a complete tumor removal, because the biology of the disease is different. But the PAUSE score essentially gives us an idea of P stands for the PCI, A is abdominal wall involvement, U is unfavorable sites, S is small bowel involvement, and E is extraperitoneal disease. And if you want to have a look at that, but there's the reference for that paper if you want to have a look at it. Small bowel involvement is the thing that really will stop us from achieving a complete cytoreduction. And again, it's useful to know this preoperatively, but often, particularly disease here at the mesenteric border, is not easy to pick up on preoperative imaging. And so when we find this at the time of surgery, if you try to remove all that disease, you'll almost certainly get small bowel fistulation. And patients will be in hospital for months if they ever leave. So we try to avoid resecting, unless it's one or two isolated spots, but often it's disease that's distributed from the DJ flexure to the terminal ileum. And that's the thing that will stop us from achieving a complete cytoreduction. There are a number of other ways of scoring the extent of disease. This is a French online tool that gives us allows us to describe the distribution and the morphology of the disease, so that you can, when you're making referrals or talking to other teams, they have a clearer idea of where the disease is and how extensive it is. Pathology is important. So this is Professor Norman Carr. He's retired now, but he's been a driving force in standardizing and describing the pathology of appendix tumors. And we've published a number of different consensus statements to try and standardize the description of these tumors, because it is very important in terms of how we manage patients. And we know that if you have a low-grade tumor and you have a complete cytoreduction, then your outcomes are much better than if you have a high-grade tumor. So it's important from that point of view. But we also know that there can be a difference between the pathology of the primary tumor and the pathology of the peritoneal disease. So, and we know that the outcomes are determined by the pathology of the peritoneal disease rather than the primary tumor. So you can get this discordance where some patients may have a low-grade primary tumor, but their peritoneal disease is actually high-grade, and it'll be the high-grade disease that will determine their long-term outcomes. And likewise, you can have a high-grade primary tumor but low-grade peritoneal disease, and those patients will do better. This is not straightforward surgery to perform, and as I say, we're one of the highest volume centers in the world now. But it's taken us 25 years of making mistakes to get to the point that we are now. Paul Sugar-Baker's there on the left, Brendan Moran in the middle, and there are now 8 of us who perform this surgery. Well, there are 5 of us that perform this surgery. There are 8 colorectal surgeons. Our morbidity and mortality has come down from nearly 14% kind of 20 years ago to just under our grade 3 and 4 morbidity, clavio-india morbidity is just under 7%. Our mortality is just under 1% now. So we can perform this surgery safely, but it does require an experienced team, both surgical, but also all the allied healthcare professionals. So our physiotherapists, our pharmacists, our nursing staff, specialist nurses, exercise therapists, anaesthetists, and critical care physicians. It's a team effort, and we've all been able to reduce the risk of this surgery and get patients through without too much trouble. For widespread peritoneal disease, our median operating time to achieve a complete cytoreduction is just under 10 hours, and that hasn't really, we're maybe a little bit quicker now than we were, but not a huge amount. And the median length of stay is just under 3 weeks for these patients. So it's a big operation, and it requires a lot of effort to get them through and to get them through safely. But we have been able to improve our complete cytoreduction rate. So you can see we've gone from just over 60% to just under 80%, and reduce the open and close laparotomies, but also those patients who are having incomplete cytoreduction. So this comes with high volume and experience. I just wanted to mention briefly, we use mitomycin C at 42 degrees centigrade for 1 hour as the intraperitoneal chemotherapy. So this is after all the tumor's been removed. We infuse the abdomen with this solution containing the chemotherapy and make sure all the surfaces are covered. We also used to use what's called early post-operative intraperitoneal chemotherapy. So this is chemotherapy instilled into the peritoneal cavity for the first 5 days after surgery. We leave a Tenkov catheter in at the end of the operation, and then infuse the chemotherapy at room temperature. There's a 23-hour dwell, and then it's drained for an hour. And then we have subsequent treatments with that. During COVID, we stopped using it, and the evidence at the moment, there's some controversy about whether it actually has any benefit or not, because it is pretty labor intensive. But you can see here, I just wanted to illustrate the number of the increase in the volume of patients that we've treated. So these time periods, these are basically the time periods that it took to treat 391 patients. And we've gone from essentially a period of 206 months to treat 391 patients to 22 months to treat the same number of patients, because we've increased our volume of cases that we do per week as we've grown as a service. Many people will say, well, is this worth it? And I think we've looked at the health-related quality of life, and for these patients, those of them that we can achieve a complete cytoreduction, many of them will live for certainly at least 10 years and then go on for 20 years without any recurrence. Then their quality of life is good, and certainly better than it would have been if we hadn't operated on them. But we do know that there's about a 40% incidence of recurrence of peritoneal disease, and that's an increasing challenge because these patients are not easy to manage. We published this nomogram to try and predict survival and recurrence in patients. We used just over 2,637 patients who were operated on over a 20-year period to try and identify those factors that may increase the risk of recurrence, so elevated tumor markers, widespread extent of disease, but also the histopathological grade of disease. All of these have an impact on survival. But if patients do develop recurrence, then we usually pick that up on surveillance imaging, or their tumor markers start to rise, or sometimes they're admitted with obstruction, bowel obstruction, or they're symptomatic, and the recurrence is detected at surgery. We know that patients with 3 tumor markers elevated preoperatively are more likely to develop recurrence, usually within the first 2 years of a complete tumor removal. So we can stratify out actually the risk depending on whether there's 1, 2, or 3 tumor markers elevated. If all 3 of their tumor markers are normal, their risk of recurrence is much smaller. The treatment options, broadly speaking, if they do develop recurrence, if it's widespread and it occurs within 12 to 24 months, then we would normally suggest that they have some form of systemic chemotherapy or systemic anti-cancer treatment, because the likelihood of complete tumor removal is much smaller. We know that the response to systemic treatment is variable, and many oncologists will say, well, look, this is a low-grade disease, there's no point. But actually, we do know that some of these tumors, despite the fact that pathologically they've been described as low-grade, don't behave in that way. And this is one of the shortcomings of our current pathological description of these tumors. It doesn't really describe their behavior, their biological behavior. But we're moving towards now understanding the molecular signature of these tumors, and we know that many of them have KRAS and GNAS mutations, TP53 mutations, and I think that's going to unlock our understanding of how these tumors behave, so that we can predict which ones are more likely to recur, and then we can give them adjuvant treatments or neoadjuvant treatments accordingly. We're not quite there yet, but this binary division into low-grade and high-grade tumors isn't quite enough to tell us how these tumors are going to behave. If patients have an isolated recurrence that's symptomatic, for instance, causing small bowel obstruction or gastric outlet obstruction, then we will consider repeat cytoreductive surgery and HIPEC to deal with that. This is our experience with managing recurrence, and I think you can see here if we can achieve a complete cytoreduction, people have the best survival. If it's debulking surgery, then not so good. We have a number of patients who will just watch and wait, so they'll have recurrence, but they'll be asymptomatic, and we'll do nothing. And because this is, on the whole, a slow-growing disease which very rarely spreads outside of the peritoneal cavity, then you can do that. And so you don't have to operate on everybody just because they have peritoneal disease. But clearly, some of those patients in the watch and wait group will either then move on to having surgery, whether that's complete tumor removal or debulking. Some of them may then have some systemic chemotherapy if the rate of change of their disease changes. And you can see here, this is the 5-year survival for those different treatment options. What happens when patients develop recurrence or they have disease that's not amenable to traditional or conventional surgery? So this is a pretty horrible disease when it's in its advanced stages, and patients develop bowel obstruction, abscess formation, both internal and external, bowel fistulae. It's a pretty poor quality of life. And you can see here, there's a patient with tumor that's essentially fungating through the abdominal wall. So these patients can't maintain their own nutrition orally, and so they require total parenteral nutrition, and it becomes very difficult to manage this abdominal wall failure. So we set about looking at ways that we could manage these patients, and with the help of the Oxford transplant team as Peter Friend and already, and Srikanth Reddy and Anil Vaidya. And the guy there with his arms crossed was the first patient who had a modified multivisceral transplant for advanced pseudomyxoma. He's a guy called Steve Prescott, who's a rugby league player who had the first transplant. He sadly didn't survive the transplant, but he was the patient who was brave enough to agree to undergo this. And the modified multivisceral transplant essentially involves depending on the extent of disease and whether it's required, it's stomach, pancreas, small bowel, or just isolated small bowel. And we published our results. We've done 17 patients now, and we published our early outcomes a couple of years ago. And we can get pretty good outcomes. The longest survivor is now 9 years from his modified multivisceral transplant. It's not for everybody. It requires a combined effort between ourselves and the Oxford transplant team. This is the longest survivor, Adam Alderson, who's now back to work as a tree surgeon, and he had his transplant nearly 9 years ago. We also are doing some work looking at the mutation analysis and whole exome sequencing of pseudomyxoma, so we can get a better idea of how these tumors behave. We know that I think this is going to be the key to managing these patients and perhaps either delaying or preventing recurrence. So, drawing things to a close, and we'll have some time for discussion if anyone wants to ask any questions. Complete cytoreduction is probably, well, we know it is the optimal way to manage pseudomyxoma. Pathology of appendix tumors is very important, and in those areas where you don't have an expert pathologist, that's where the challenge arises. We know that there are some prognostic factors to select patients who are going to benefit from surgery. There is a learning curve in doing this type of surgery safely and successfully, and managing recurrence is a growing challenge. There are some exciting developments on the horizon. There's a tumor vaccine that's been developed by the Norwegians for patients with a GNAS mutation, with essentially tumor vaccination and then checkpoint inhibition to try and stop the production of mucin. The GNAS mutation is associated with mucin production by these tumors, and if we can switch that off, then that may be the key to managing recurrent pseudomyxoma. Thank you for your attention.
Thank you very much, Fahid. It was an excellent presentation with lots of insight. I am going to bring in my colleagues to have some discussion. First, I will start with Rachel Aguilo. Rachel, questions, comments?
Well, Fahiz, hello, nice to meet you. Absolutely stunning. Thank you so much, so insightful. As lead for emergency general surgery in our trust, obviously, unfortunately, we do find things that are quite surprising. And yes, and it's interesting, especially if Safli, it's not just the appendix that we might see that might be inflamed, even if it's just that reported by the radiologist, or even if the radiologist says, oh, it could be appendix, or it could be a tubo-ovarian abscess. And of course, in a DGH, the natural thing to happen in theatre would be to invite your obstetric and gynecology colleagues in to have a look. What would you suggest that we might do, especially if we do see, and this did happen last year, where I found a nasty looking appendix, we found jelly, and it almost looked like there was a concurrent tubo-ovarian abscess. And of course, the gynecologist swooped in, very excited, and whipped out the fallopian tubes and the ovaries. So in this instance, I'm sure I'm not the only one that's experienced this. What would you recommend that we would do?
Yeah, no, it's a very good it's a very good question that you ask, and it's a common scenario, as you say. I think so. From our viewpoint, the majority of these tumors are low grade, and what that means is that the majority, again, will not require any more treatment than an appendicectomy. So if you have the opportunity to take the appendix out, if you can do it safely, then it's very useful for us to know what the pathology is. So let's say that in that situation, the ovary and the fallopian tube have been removed. If it's safe to do so, remove the appendix. Now, if that requires mobilizing the right colon a little bit, just so that you can put a stapler across, any form of stapler across the base of the appendix, and perhaps take a cuff of the cecum, then we can look at that pathology. And for those patients with a low-grade tumor, we would say we will just keep an eye on them, because the majority of them will not have any more trouble. But if it's a high grade, if it comes back as a high-grade mucinous tumor or an adenocarcinoma, then we will say, well, look, the fact that you haven't done a right hemicolectomy is good, because those anatomical planes haven't been disrupted. Doing a right hemicolectomy on its own is probably under treatment. So send those patients to us, and we will do a more extensive operation after having a discussion with the patient to see if that's what they want, because it's equally, acceptable to keep them under surveillance as long as people know the risks, because not all of those patients will run into trouble, even if they have a high-grade tumor, but the risks are different. So to answer your question, if you can do an appendicectomy, that's often all that's needed. Don't worry too much about spilling the mucin or the contamination there, because often, again, if you just wash out the peritoneal cavity, for many of these patients, they have what's called acellular mucin, so mucin with no epithelial cells or very few epithelial cells. So if you wash things out, and water, after all, is cytotoxic, but I know many of you use normal saline, either way, it will just wash that jelly away, and it may never come back. And so even if there is jelly left behind, we know that 40% of those patients with acellular mucin, it will resolve itself. It will be reabsorbed. You do a scan in 6 months' time, in a year, there's nothing to see. That would be our recommendation.
Great. Thank you so much. Thank you.
Thank you, Fahiz, and thank you, Rachel. Hamza.
Hi. I'd like to echo Rachel's comments. I think this talk has been more than professorial. Thank you so much. I've learned so much. It's amazing. I have loads of questions. Going on from that last statement, is there still a role of the right hemicolectomy? It sounds like, this thought that we can get away with a right hemicolectomy is very much old-fashioned, and we shouldn't be doing it for this disease.
Yeah, I mean, for the low-grade tumors, there's really no role for a right hemicolectomy, because the incidence of lymph node involvement is very, very low. I mean, it's probably 1%. So the majority of people will not need it. But for high-grade tumors, the right hemicolectomy on its own can actually be detrimental, because once you've mobilized the right colon, you've done a right hemicolectomy, whether you do it laparoscopically or open, all of those planes will be exposed potentially to peritoneal disease. And we know that when people do develop peritoneal disease after they've had a right hemicolectomy from a mucinous tumor, then it can be much harder, because that basically, when you drop the duodenum down, you open that space. When you get disease around that D2 area, it's almost impossible to remove. Or it gets involved in the gonadals, or the stuck onto the ureter, because all of those areas will be protected if you don't mobilize them. But if you open those spaces up, it then makes it much harder. So I would agree. I think that you really need to think very carefully before performing a right hemicolectomy. Now, clearly, sometimes if you have a very large appendix mass and you cannot remove it with just an appendicectomy alone, then you have to do what's needed to get the tumor out, if that's the priority. But again, if you think that's what's going to be needed, and the patient is well, because many of these patients will present, even if they present with an abscess, if you treat them with antibiotics, perhaps put a percutaneous drain in, And again, if you're thinking of putting a percutaneous drain, is if you can keep the drain as close to the midline as possible, it makes it much easier for us to remove the drain track and clear all of that area. If you put drains in the flank, then you often get tumor basically traveling down those drain tracks, and it makes it much easier to clear that, core those drain tracks, much harder, sorry, to core those out surgically. You have to have the patient on their side, and then it's you get tumor fistulating down to the psoas. But yeah, if antibiotics and percutaneous drainage settles them down, then there's no rush to operate. We can see them, and then we can do more definitive surgery.
So that's an interesting point, because the diagnosis is often achieved via a CT scan. And where I work, you're not going to get a confident radiologist put their neck out and say, I'm concerned about mucinous neoplasm. So my next question goes on to two things. Firstly, from what you've mentioned, your numbers are getting higher. Is the incidence rising? And the second thing is there anything we can pick up from history, examination, old-fashioned skills that might make us aware that, hang on, this is more than just a simple appendicitis?
Yeah, the incidence is rising, and there's evidence. There's a recent paper establishing that. Why that is, I don't know. And again, is it because we're taking fewer appendixes out? Because we've just changed our approach to appendicitis. I don't know, but there is an increased incidence, and maybe that's in line with the increased incidence in early onset colorectal cancer, changes in the gut microbiome. Who knows? It depends. You choose what your conspiracy theory is, and it's one of those. But it is rising in incidence. Yeah. To answer your point about the history, I think if you've had So anything to suggest more than just a simple appendicitis, so a longer onset of pain, any complications of appendicitis, then I think the alarm bells need to start ringing. One of the challenges is often there won't be any of those traditional signs in the history. Patients don't always have pain, or if they do have pain, it may last for a day, and that may be when the appendix is perforated, the tumor is perforated. They've not been unwell, but then things have just ticked over. Where things tend to progress more rapidly is in women, younger women. When the ovaries get involved, those ovaries grow very quickly. And that's where the diagnostic confusion arises, because often they're then referred to the gynecologists. Again, we've been trying, and I think successfully, to educate the gynecologists and to say, look, not everything that involves the ovaries is ovarian cancer, and that some of these tumors are Krukenberg tumors, most commonly from the appendix, but also from colorectal cancer. And so patients don't waste time, or they're not sent to the wrong place where they have a hysterectomy, a BSO, and then they're found to have a pseudomyxoma from an appendix tumor, and so they're referred to us. It still happens, and sometimes it's inevitable, because unless you have a very experienced radiologist, it's not easy to pick up that primary appendix tumor, and it can be a challenge even for our radiologists sometimes. So yeah, I think, however, despite very good history taking, I think we'll still have patients who don't follow the normal patterns and who will present to us, and it will be a surprise. But just having that increased awareness, and it's always going to be difficult, isn't it, for rare diseases like this, where many clinicians will never see a case of this in their careers, and if they do, it will be maybe one or two. Certainly, if you're thinking about general practitioners, almost even less. For a specialist, we might see more, but for general practice, and so it is a balance, isn't it, between raising awareness but also being realistic that we're still going to miss some of these patients.
Thank you, Faiz. Yeah, thank you, Hamza. I am now going to go to Bangladesh Medical University Hospital. I don't know if you've noticed, Faiz, we have all the eminent surgeons in a room, which is excellent. So can we start, please? Questions, discussion from Bangladesh Medical University Hospital. Can you hear us?
Sugandha.
Yeah, thank you. We can hear you now.
Student? No question. Arifa.
Hello.
So, Bangladesh Medical University, Dhaka Medical College, Saradi Medical College, Mymensingh Medical, Rajshahi, Chittagong,
Excellent.
Mitford, your medical college. So all are connected. So thank you.
Excellent. Thank you.
And thanks for the very beautiful presentation, Faiz. And it's a complicated chapter, in fact, very complicated, because decision making is really tough. Sometimes we get something like post-appendicectomy patient is absolutely fine, but we are concerned about the histopathological report. And nowadays we do some MDT, but still very difficult to decide whether we should go for right hemicolectomy or not. That is the main concern. And it's very tough decision, because right hemicolectomy is not giving any immunity for the total peritoneal cavity. So that is a very important issue. And mostly, whether this is low grade or high grade, from the histopathological slide, this is another important issue we consider. So, Faiz, sometimes we face some problem, like, the CT scan. So less than 5 millimeter peritoneal seedling, conventional CT can detect only 20% lesion. So sometimes during surgery, when we get, say for example, left colectomy and PCI, very low PCI operatively when we find around less than 10. But Bangladesh, there is no facility for high pay. So what is your suggestion? Should you go for the only CRS? And if we feel it may be CC0 or CC1, and there is no scope of high pay, what should you do? Do you think we should go for CRS only and subsequently systemic chemo, or we should keep it as it is and refer to, currently we should refer to abroad for high pay? What is your suggestion?
Yeah, that's a very good question. So we know now, and those of you may have heard of the Protégé 7 trial that the French did, where they randomized, this is patients with colorectal cancer, colorectal peritoneal metastases. They randomized them to two groups, one that had HIPEC and the other group that didn't have HIPEC. The HIPEC regimen that they used was a high dose oxaliplatin. It was 460 milligrams per meter squared for 30 minutes. But what they found was actually much better overall survival than they expected with the surgery in both groups, but no difference in overall survival, and actually more complications with that particular regimen of HIPEC. So the conclusion drawn was that surgery, high quality surgery to remove the disease in patients with low PCI is effective. What is uncertain is how much the HIPEC adds. So we know that there is some evidence to say, again, the Spanish have recently published a trial looking at T4 cancers and the use of HIPEC as a prophylactic measure, and they found some reduction in local recurrence with the HIPEC, or delay in local recurrence. So and that was with mitomycin C at a 35 milligrams per meter squared dose. So to answer your question, yeah, if you don't have HIPEC available, should you go ahead and remove that disease? I think the practical thing to say would be yes, because we know that surgery, when we achieve a complete cytoreduction in a low volume PCI of 5, for instance, that has a benefit, a survival benefit. If you have access to HIPEC, then give the HIPEC as well. But if you don't, then I think the most important thing is getting those patients to systemic treatment as quickly and as safely as possible without complications. If they have complications from surgery and it delays their start of systemic chemotherapy, that will have a real impact, which is why I think performing the surgery safely, getting them through without any complications is probably more important than anything else.
Okay.
Thank you. Thank you, Faiz. Any further questions, sir?
Yeah, and there is, actually, I have gone through that Prodigy 7 that they study, and that is the hope currently for Bangladesh, as there is no HIPEC. So, what do you think about the routine second look laparoscopy? Because it's very difficult to decide the PCI. Preoperative decision making is very difficult. But the high risk group, in your institute, what do? Do you go for the after 6 month routine laparoscopy to see these peritoneal maps?
No, we don't. I mean, we used to use a lot of laparoscopy, but now we've really reduced that use because it's not easy to perform diagnostic laparoscopy in patients who've had previous surgery. The risk is much greater. And I'm speaking from personal experience. When you're looking inside the small bowel rather than the peritoneal cavity, it's not so great. And you can create a lot of trouble. But also, there are hard to see areas in laparoscopy. You know, you'll miss disease in the DJ flexure, you'll miss disease deep in the pelvic cul-de-sac. So I have to say our main surveillance tool remains CT, but with positive oral contrast and intravenous contrast. There's a lot of interest in MRI, diffusion weighted imaging with MRI, and across Europe, the radiologists are very excited about it. But I have to be honest, it is very much dependent on the radiologist and also your access to MRI. It's probably not as useful as people think it is because it still misses those lesions which have been hard to pick up traditionally. It's, you know, sensitivity is probably only 50%, and there's some recent publications supporting that. So, to answer your question, no, we don't do routine second look laparoscopy or routine second look laparotomy. We rely still on CT. You're right; you're going to miss some of those small lesions, but again, you know, the majority of these patients with colorectal peritoneal metastasis will develop recurrence, and it'll be peritoneal or peritoneal and systemic, and that will happen within 12 months of their surgery. If they have cytoreductive surgery and IPEC, the majority of them will develop recurrence. So whether you pick that recurrence up a little bit earlier or a little bit later probably isn't going to make a huge amount of difference because most of those patients will need systemic treatment. Only a very few of them will be suitable for repeat surgery.
Okay. Thank you. And sometimes we find many patients with the huge peritoneal mass, like especially in the PMP. So what is your suggestion about the load reduction from the abdomen? Is it really helpful, or what do you think? Or should we usually do sometimes take some biopsy and go for the molecular profiling? Unfortunately, if the patient is MSI high, this patient can afford, they can get some immunotherapy. But especially in the PMP, load reduction is a surgeon intention to reduce some load from the abdomen. So what is your suggestion?
Yeah, I think if you can do it safely, then it certainly helps with quality of life, with helping patients to maintain nutrition enterally. So I think if you're doing a planned debulking to allow patients either to get systemic treatment or to help their because some of these patients will be deconditioned and they're not well enough, but they're too frail to, even if you can remove all of the disease, it may be more sensible to do this staged procedure where you debulk, get them physiologically better, maybe have some systemic treatment if it's suitable, and then you can always revisit the situation and attempt a complete cytoreduction. But I'd caution, I think the role of HIPEC for PMP, appendix tumors, is probably stronger than it is for colorectal mets. So I think what I would say to you is we need to set up a HIPEC center in Bangladesh, don't we? As soon as possible.
Yes, I think so.
I think you have all the skills there. There's no reason why it can't be done. You know, you've got the skilled surgeons. Okay, fine. The infrastructure may be not as developed as some other countries, but it's more than enough to have a HIPEC center. The fact that your room is full there's certainly people who are interested, which is really, you know, heartening and encouraging for me to see. So it's probably our responsibility to help you.
Thank you. People are very much interested. And that's a different type of question. How are you satisfied with your work with this CRS?
How are we satisfied?
Yeah, you.
Yeah, me. I mean, alhamdulillah, I think the diseases we treat are fascinating. There's a lot we don't understand yet. The surgery is exhilarating. I mean, I'm lucky I'm part of a big team, so I'm not on my own. I couldn't do this on my own. So I have colleagues. We usually operate as a team. So we'll have 2 senior surgeons and we'll divide the operation. So one of us will operate for 3 or 4 hours with a fellow, and then we'll swap. Then someone will come in fresh. And that way you can keep the momentum. You don't get tired. You don't take shortcuts. You don't make mistakes. And we can safely get through the operation, but keep the time of the operation as short as we can. And we normally have 5 or 6 fellows from around the world, and so we can train them as well.
Thank you.
I think meanwhile, Rachel had a question. Rachel.
Thanks, Zarifa. Fahiz, before I ask the question, I've got to say it is so delightful to see someone who's still so infused and in love with their specialty. It's really
it's rare, isn't it?
Well, I would say that. Well done. It's so wonderful to see. So I just want to say that as a bariatric upper GI and general surgeon, when we ask for oral contrast, to us, the positive oral contrast is one really where we're looking for a leak test and we're looking to see extravasation of the contrast. What do you mean? I've noticed you use the word positive oral contrast. Are you using the word positive with a different meaning in this case?
No, absolutely no. So just not water, basically. So oral contrast.
Fine. Fantastic.
Rather than water.
Thank you. And one last question. So when we have our trainees and they stick the umbilical port in, this is with a view to diagnostic laparoscopy, you know, until you've got either severe head down or severe right side up, you're not going to find the appendix. So even though it would be lovely to assist in future and have all of our ports placed in the midline, it is not the natural position for us to put our ports in the midline. Do you think then perhaps we ought to be perhaps adjusting the way that we approach our diagnostic laparoscopies?
You know, I think you've got to do what's safe and what you're comfortable with. So we certainly wouldn't dictate. I think if it's possible, then it makes it easier. Resecting ports, I mean, you'll know yourself, is not an easy thing to do. And often, even though a port feels, you know, if someone's had surgery a few months ago, the port will be indurated, thickened, but it may not necessarily have any tumor in it. So we've stopped routinely resecting ports that are off the midline unless we've got a high index of suspicion, because they create a lot of trouble and many of them are negative for tumor. So to kind of to answer your question, yeah, if you can do it, then do it. But if you can't do it, or logistically or from a safety point of view, it's just not feasible, then yeah, clearly use your standard ports and we'll work around that.
Great, thank you.
Thank you very much. Thanks, Rachel. Can I ask Dhaka Medical College if you have any questions, comment? Hi.
Assalamu alaikum. Me, Dr. Mohammad Nurul Kabir. I am a FCPS specialty trainee of Dhaka Medical College Hospital. Thank you, presenter, for your brilliant and excellent presentation. I have a query. What is the follow-up protocol after appendicectomy in case of low-grade appendiceal mucinous neoplasm?
Walaikum assalam wa rahmatullahi.
Thank you.
So we would currently recommend a CT scan 1 year, 3 years, and then 5 years after appendicectomy with tumor markers, CEA, CA125, and CA199 at each scan. And also, if not performed within the last 12 months, we'd recommend a colonoscopy.
Thank you so much.
Yes, please, Dhaka Medical College.
Assalamu alaikum. Thank you, presenter. I am Dr. Ghulam Mustafa, Assistant Professor, Colorectal Surgery, Dhaka Medical College. I have a query. Just from the book teaching or during our training period, we got the recommendation of right hemicolectomy in case of appendiceal tumors regarding size. If it's more than 2 centimeters in size, then go for right hemicolectomy, and if it is not, then only appendicectomy and watch and wait. So is it a paradigm shift that we should follow now, not the size, rather is the low grading of the tumor? That means low grade and high grade. What do you think?
So I think that 2 centimeter cutoff refers to neuroendocrine tumors. So neuroendocrine tumors of the appendix is a very different entity. And I haven't really touched on that today because that has its own, that's a huge topic on its own. And actually, the neuroendocrine tumors that have metastasized to the peritoneal cavity, there's no strong evidence that CRS and HIPEC has a benefit there. And you've got lots of other medical treatments octreotide. You've got the risk of liver metastases. So for neuroendocrine tumors, that 2 centimeter cutoff, that still stays. There's no paradigm shift there. We're talking about a separate group of appendix tumors, but where the size is less important.
So how can we clinically be sure that it's mucin secreting? Is there any tool on direct vision as well as the preoperative scan? Is there any?
Well, I showed you a few pictures of what the mucinous tumors look like, and they tend to be, and they don't all look the same, and it's not always easy to diagnose what they are preoperatively without histopathology. So I think I know what you're saying. Well, how do we know if it's a neuroendocrine tumor or not? Should we do a right hemicolectomy? I guess, you know, if you can avoid a right hemicolectomy, then you're not going to lose anything by doing the appendicectomy alone, because you can always go back and do a right hemi, because most of you, I guess, will be doing the appendicectomy laparoscopically. Is that right? Or would you be doing it open still? I guess it'll depend on expertise, but you've still got the option of going back to do the right hemi. Whereas if you do the right hemicolectomy straight away, there's no going back. You've made the decision. There's no other choice.
Thank you, sir.
Okay, thank you very much, Dhaka Medical College. Can I now go to Sir Solimullah Medical College? Do you have any questions for us? Sir Solimullah Medical College, I take it as a no. Can I go to Shohid Sarwardi Medical College if you have question for us?
I'm Dr. Mahadevan Shira, HCPS training and the portion. During diagnostic laparoscopy, appendicectomy is not feasible. Then we should take biopsy. How we should take biopsy? What are the options?
Yeah, that's tricky, because if there's no disease outside of the appendix, then it's not easy to take a biopsy unless you can see an obvious peritoneal lesion either in the omentum or and the right paracolic gutter. If everything is contained to the appendix and you can't do an appendicectomy, can you hear me?
Yes, we can.
Yeah. If you can't do an appendicectomy, then your options are limited, aren't they? Because you either then have to do a right hemicolectomy, or you don't make a diagnosis. I don't know if that answers your question.
Rohit Sarwardi Medical College, do you have any more questions? Did you hear the answers? We cannot hear you. I think you're on mute. I think you're still on mute. Yes. Yeah, we can hear you now. Hi, we can hear you. Do you have any questions?
Assalamu alaikum. Oh, this is from BMU again.
Okay. Yes.
President of colorectal surgery from Bangladesh Medical University. So, during surgery, if we found a mucinous neoplasm, a mucinous tumor originating from the ovary, is there any role of prophylactic in this patient?
Is there any role for? Sorry, I lost the last bit.
If it is suspected mucinous neoplasm from ovary, is there any role of prophylactic appendix?
It's a very good question, because most of these suspected ovarian tumors arise from the appendix. So I think if you have the opportunity, take the appendix as well, because then you'll remove any diagnostic uncertainty. So if you can do it safely, even if you suspect it's an ovarian primary, take the appendix.
And if it is vice versa, like appendicular neoplasm, mucinous neoplasm in a premenopausal women, is there any role of prophylactic operation?
There is, but you have to counsel the patient very carefully. And do you take both ovaries and fallopian tubes? Do you just take the right ovary and fallopian tube, leave the left ovary, on the understanding there's a risk of Krukenberg tumors developing in the future? Do the patients go for egg harvesting, ovarian stimulation, egg harvesting, freezing of the embryos? Can you preserve the uterus? All of these things are things you need to discuss. If you have a low-grade mucinous tumor of the appendix, then ovarian stimulation is less risky. If it's high-grade or an adenocarcinoma, then there is the chance that you may accelerate the development of Krukenberg tumors when you stimulate the ovaries with for egg harvest. So you need to discuss all of that. And for colorectal cancer, definitely egg harvesting, stimulation of the ovaries, egg harvesting, and then freezing of embryos. There's a much higher risk if you know that there is peritoneal disease.
Thank you, Fahiz. I have on the audience Professor Salma Sultana. She is head of department for Dhaka Medical College. She wanted to discuss a case. Are you there, Appa? Okay, maybe she's not there anymore. Mohammed Medical College, do you have any?
Hello,
any?
Arifa.
Oh,
I'm
hello,
sorry.
hi.
Hi, Arifa. Are you fine? Okay, thank you, Arifa, for arranging such a beautiful session, and thank you to the speaker. Actually, it was an amazing discussion, I should say, and presentation, and we have learned a lot. Most of them are yet not practicable in our country. The patient I wanted to discuss was that I got a patient a few months, I think 1 month back. And the patient is a young lady. She was around 26, 7 years. She had an appendectomy 1 year back. And it was a clean cut appendectomy, routine appendicectomy. And the histopathology came as an adenocarcinoma of the appendix where the base was involved. And at that time, the patient was referred by the surgeon, primary surgeon. She was referred to an oncologist. And the oncologist gave her the chemotherapy. She received 8 cycles of chemotherapy. And later she had pain in the right iliac fossa and everything. So the oncologist, at the end of this adjuvant therapy, she was referred back to surgeon for right hemicolectomy. And throughout the time, her PET CT scan was normal. There was nothing. But the CT scan, as the speaker was telling, that the role of radiologist, the reporting of the radiologist is very important. Though the PET CT scan was normal twice, last January and this July, still the contrast enhanced CT scan said that there is a local recurrence involving the right ovary, small bowel, momentum, and all these things. So we did a tumor board, and the decision was made for the right hemicolectomy. And before doing the hemicolectomy, I did the laparoscopy and said that, as we were confused regarding the reports of the PET CT and the contrast CCT. So I did the laparoscopy, and it was the local recurrence involving the right ovary and everything, and there was seedling within the local peritoneum. So as the decision of the board, I did the palliative. I should say it's a palliative right hemicolectomy. But the question is, what should be the standard management in such type of situation where in our country the HIPEC or in all those advanced surgery facilities are not available? That was my question. She is receiving now again second cycle of chemotherapy, but I have seen that I have left the peritoneal seedlings in the right iliac fossa. So that was my question. What should be the standard management in a patient who was diagnosed post-operative, post-appendectomy as an adenocarcinoma of the appendix having the base involved?
Yeah, that's a sad situation, but it's not uncommon, unfortunately. Just the 2 points, I guess. The PET CT, so for mucinous tumors, wherever they arise from, PET isn't that good. So
Yeah.
PET always understages. So I think CT, you're absolutely right. CT, just a plain CT with contrast and oral and IV contrast is more likely
Yes.
to pick up things. If in this situation where you have peritoneal disease, the standard, what we would accept as the standard care would be peritonectomy, stripping the peritoneum on that right-hand side, taking the ovaries, fallopian tubes, taking the omentum, doing the right hemicolectomy, and giving HIPEC. That would be our recommendation. Now, clearly, if that's not available to you, then should you strip the peritoneum when you don't have access to HIPEC? That's a very interesting question, because if once you strip the peritoneum, you're removing the body's natural defense against further tumor invasion. So if you strip the peritoneum, you don't give HIPEC, and they get recurrence, it's almost impossible to remove it. So I guess your question is, should you leave that disease, which is what you did, and just rely on systemic treatment? I guess that's the best you can do. Is it the optimal treatment? No, it's not. Certainly not in our experience, because we can achieve some good long-term survival with the approach of peritonectomy and HIPEC. So I think when you have these situations where there's tumor at the appendix base, and often people will say, well, should we go back and do a right hemicolectomy? If it's a low-grade tumor, I think there's very little reason to do that, because in our experience, you very rarely find tumor if you go back and do a right hemicolectomy. And actually, in a way, it doesn't really matter. If it's high grade or an adenocarcinoma, then there's a stronger reason to do some form of completion surgery. But I think the decision to give systemic treatment was absolutely right, based on the fact that you had histology. Even if the base was involved, then systemic chemotherapy in that situation is entirely reasonable. We know that a significant proportion of these patients will develop peritoneal disease, as they did. And if you don't have access to cytoreductive surgery and HIPEC, and it's not just the HIPEC, it's actually the whole approach, it's the surgery and the combination of treatments, then you're probably, doing what you did is I think is reasonable.
Actually, in our MDT, the debate was there why the surgeon didn't go for the completion right hemicolectomy, as it was a high-grade tumor, adenocarcinoma, and Bayes was involved. That
Yeah,
was the
but
debate.
yeah, no, but I think you made the right decision was made. I don't think doing a right hemicolectomy would have added anything in this situation. It might have made things worse, to be
But
honest.
the patient, in spite of getting the chemotherapy full course, she developed the local recurrence.
Yeah. And that was probably going to happen anyway, whether you did the right hemicolectomy or
Do
not.
you think if the primary surgeon have done the right hemicolectomy in the first instance, then the local recurrence would not?
No, I don't think that.
You don't think?
I don't know, but in my own personal opinion, I don't think so.
That's an excellent
Okay.
question, Appa. Can I go to Mymensingh Medical College, please? Is there anyone from Mymensingh Medical College?
Yes, thank you very much. Thank you very much for arranging such a nice presentation. I am Dr. Habibur Rahman, specialty training of colorectal surgery, Mymensingh Medical College. Ma'am, my question is that we are not so much familiar with HIPEC plus CRS as it's a peripheral medical college of Bangladesh. Usually we are very much familiar to do the CA and CA99 for diagnostic plus prognostic factor of colorectal carcinoma. My question is that, especially the role of CA125 in case of appendiceal neoplasm. Thank you.
Yeah, so in men and women, it's a pretty sensitive marker of peritoneal disease. So yeah, traditionally we use it to monitor ovarian cancer, but actually it's equally useful for peritoneal disease. And I think we know that for colorectal cancer and for appendix tumors, elevation of all three tumor markers is a bad prognostic indicator. But within that, CA19-9 is probably the strongest prognosticator of bad outcomes if it's elevated. So if you have a CA19-9 of in the thousands, those patients do badly.
Thank you very much.
And the CEA is very useful because if the CEA is elevated and there's some uncertainty about the primary tumor, whether it's ovarian or a lower GI, if the CEA is elevated, it's almost always lower GI. It is very rare to get an elevated CEA with a primary ovarian tumor.
Thank you, Fahiz. Is there any other question from Chittagong Medical College and any other medical college?
Thank you.
Any other? Yes, please.
I am Dr. Mohammed Noran Bhuya from Chittagong Medical College.
Thank you.
Speaker, for your amazing presentation. I have a question. If we find during laparoscopic appendicectomy, there is perforated appendix with mucinous ascites, what will be our standard management protocol?
I think if you can take the appendix out safely and wash out the mucin, that's probably all you need to do. Get the histology.
Okay, thank you. Thank you, sir.
Any other question from Chittagong Medical College?
No, madam, it's okay.
Thank you so much. Any other question from any other medical college? Any other question from the...
From BMU, Bangladesh Medical University.
Yes, yes, please.
I am Dr. Krishna Badhu Shah, Assistant Professor, Colorectal Surgery Department. I want to share my personal experience, recent experience with you because very recent, 3 weeks ago, a gynecologist called me while he performing a laparotomy for ovarian cancer. When I attend the OT, then I saw that the abdomen was full of mucin, and it was a case of ovarian malignancy with pseudomagma peritoni with involvement of the appendix. The appendix was tip was fan shape with mucin. Then we have done oophorectomy with appendicectomy and stitching of the peritoneum in the right from right paracolic girdle with debulking of the mucin. And after that we have a thorough peritoneal toileting with warm water, normal saline. Now, what could be done in our setting as we have no the option of IPEC? At this situation, it is a common situation in our country in different hospital and different places.
Why warm water in spite of
We have to get some high-tech machines for Bangladesh
right now.
Yeah, this is crazy. They're not that expensive. You know, we're talking about 50,000, well, probably $50,000 for a machine. And then it's a decision making. The machine is, you know, in the HIPEC is not the important thing here. It's just it's the decision making, but the surgical expertise is there. So this is not. I don't think this is an insurmountable situation. We just need to move forward, don't we, Arifa? We can talk about this, and we need to
Definitely.
how we.
Definitely. We would definitely take up that offer, Fahiz, as we discussed before. I'm going to ask anyone in the audience. I can see lots of people in the audience who has keen interest in colorectal surgery in general. Anyone in the audience have any other question, any particular case we want to discuss?
No, I have
Thank you,
another
madam.
question.
Yeah, can we go to Monirul Islam, please?
Yes, ma'am.
Yes, hi.
Thanks, the presenter, for excellent presentation and brilliant paper shows here. Actually, we see some evidence that there are, even after complete cytoreduction, there are chance of recurrence is high. And on the other hand, it showed here that even debulking has some role. So the question arises, how could we help by the debulking surgery in this patient actually? Because if we think about the disease-free survival, it will not increase by the debulking surgery. So what are you thinking about that we can palliate the symptoms, but it is only for palliation? Do you think later on we can go for cytoreduction in this patient, which was initially dealt with debulking only?
So I guess we need to be precise about the disease type. So we've just focused on appendix tumors and colorectal cancer, but for many of you, ovarian cancer is probably the tumor type that has the biggest incidence of peritoneal disease. So that's different again, because most of those tumors are chemosensitive, and so they'll have had some form of systemic treatment at some point. And there's another debate going on about whether HIPEC has a role in ovarian cancer, which again I won't go into, but there are trials going on, have been trials published showing that there is some benefit in survival. To answer your question about, oh yeah, okay, fine, if we do tumor debulking, usually the reason we do tumor debulking is because we can't achieve a complete cytoreduction, mainly because the small bowel is involved. So in that situation, you're never going to be in a situation where you'll be able to achieve a complete tumor removal. So then you just need to focus on getting the best result from your surgery with the least damage or risk of complications. So patients need to have a safe operation, which is why we tend not to deal with upper abdominal disease. If they're symptomatic from an emmental cake or bowel obstruction, deal with that, but leave the rest of the disease that isn't going to cause them immediate trouble, because that will increase the complications and the morbidity from the procedure. But I think it's rare to have a situation, unless you're doing a planned procedure to get someone physiologically better, and you know that you could come back then and deal with the rest of the disease, then you would do something to palliate them. But yeah, I think it depends on the setting and the disease type.
Thank you very much, Fahiz. Is there anyone else has any discussion point, any question from the audience, please?
From Rajshahi Medical College, Mugda Medical College. Anyone? So Faiz,
I have a question.
Okay.
Yes. Yeah, no, you go first.
Okay, last question. About the debulking and chemoconversion and re-evaluation for the cytoreduction near future. How about that?
So what disease are we talking about?
So like the last question you asked about debulking, and sometimes initially they use PCI and we go for the conversion chemo and reconsideration of CRS and IPED. So what is the harm with the initial debulking and adjuvant chemo as a conversion chemo? And we can reassess the patient for the CRS.
Yeah, I guess so. I mean, I think if the small bowel is clear and you can achieve, if you think surgically you can achieve a conversion, you have to remember most of these tumors won't be chemosensitive. So the chemotherapy is probably not going to make a huge difference unless they're high-grade tumors. But then you have to argue, well, why didn't you clear the disease in the first instance? But if you didn't clear the disease because the patient was frail, physiologically they couldn't tolerate it, then yeah, okay, surgery. And we were having this debate just last week. We all met in Barcelona. We had a big international meeting, and we were talking about this staged procedure: surgery, chemotherapy, surgery, HIPEC, chemotherapy, and then surgery again. Yeah, if you think that the patient's going to tolerate that and they're going to benefit from that, then yes. I guess from our point of view, if we can clear the disease in one go and the patient is well enough to tolerate that, then that would probably be our preference. But that's not easy because it requires a skilled team to be able to get things through safely.
Any other questions, sir, from BMU?
Yeah.
Good afternoon. I'm Dr. Salman, President Colorectal Surgery, Bangladesh University. And thank you, President, for such an insightful presentation. So my question is, in case of suspected appendicular neoplasm, if appendectomy is feasible, then the option is appendectomy. But if appendectomy is not feasible, the option is biopsy. But we all know that biopsy increases the risk of perforation, increases the risk of mucin extravasation, and increases the risk of local recurrence. So my question is, what is the rationale of doing biopsy in case of suspected appendicular neoplasm?
Yeah, there probably isn't a role for biopsy, to be honest, because if you can't remove the appendix with an appendicectomy, then you'll have to do a right hemicolectomy. There's no choice. Because doing the biopsy doesn't really further things, because someone's going to have to take the appendix out. So it's either you or someone else, and it'll either be an appendicectomy or it'll be a right hemicolectomy. So doing a biopsy probably is. Yeah, if you have to do a right hemi to get a biopsy, then that's what you need to do to get the.
So I have a question now. That's been excellent presentation and excellent discussion from everyone involved. So for normal surgeons, for example, like us who are not peritoneal malignancy expert, you go and see an appendix. You can see there might be a mucocele or it might be a tumor. So my understanding from today's discussion is, if we can safely, we should just take the appendix out.
That is absolutely correct. Yes.
I'm just trying to make this loud and clear for everyone, including trainees involved. Do not go for right hemicolectomy. If you want to find out what's next, there will be again another next stage. But please just take the appendix out.
Yeah, if you can, if it's safe, if it's feasible and safe, then yes. But if you have to do a right hemicolectomy because that's the only way the appendix will come out, then you have to do a right hemicolectomy, because we just need the histology and then we can plan.
Definitely. The other thing I would like to reiterate, that if we have treated conservatively, sometimes we do because the patient presented late, there is a appendicular mass which was treated either with antibiotics, then going forward, they must have a colonoscopy and have an interval appendicectomy. Is that correct, Fahiz?
Based on our experience, yes, that is what we would recommend.
Okay. And in an event, another situation that we discussed, that you go in, it's perforated, however, you can see some mucin, we would still just do an appendicectomy and warm water washout.
Yes.
Yes. Okay. So we are concluding the webinar quite soon. I would like to thank you everyone, in particular Fahiz, to giving up your time on Sunday. This is excellent. And also my colleagues, Hamza and Rachel, thank you so much for giving up time on Sunday. Rachel, bless her, she even moved her piano sessions to accommodate the webinar. And I would like to extremely grateful and thankful for all the medical colleges who has colorectal unit in Bangladesh to join and giving up your time. So thank you so much. And in particular, Professor Shahadat Sheikh Sir, because he is the driver of this progress and he has made everyone join, I can see. So thank you so much, sir.
Thank you, Alfa, and thank you, Faiz, and thank you, Malik and Rachel. So, big hand for them.
Thank you so much. I am sure we will be in discussion, and thank you, Faiz, for the offer. You know what? We probably will take up the offer to set up a HIPEX center soon, hopefully.
Well, I hope to see you all in Bangladesh soon, inshallah.
Inshallah. Thank you so much. Bye-bye.
Bye-bye. Well done.
Bye-bye. Thank you, Arifa. Thank you, everyone. Bye.
Thanks, everyone.
Bye.